Hello and welcome everyone. Today we'll be discussing an important aspect in the ICU, that is the management of pain and sedation. So why pain and sedation management is important in the ICU? It gives the most important thing, that is comfort to patients who are already critically ill. It is necessary because we are performing a lot of invasive procedures and to do it safely. Prevents distress, chronic pain and post-traumatic stress disorder after the ICU discharge. Uncontrolled pain will increase the oxygen demand, increase the level of the stress hormones and metabolic rate, delaying recovery. So let's first go through the bundle for ICU care of sedation, that is A, B, C, D, E, F. A is assess, prevent and manage the pain. B, both spontaneously awake trial and spontaneous breathing trials must be given to the patient. C. Choose appropriate analgesia and sedation. D. Delirium assessment, prevention, and its management. E is early mobility and exercise to prevent muscle loss. And finally, family engagement and empowerment in the patient care. So first we will go through the pain management. First we need the pain assessment. Since pain is subjective, the severity of the injury does not always match the intensity of the pain felt by the patient. It will vary from patient to patient. So routine pain assessment will improve the outcome because it helps individualize the treatment and prevents over and under treatment. Validated pain scores needed to be used. For communicating patients, use numerical rating scale or visual analog scale. For non-communicating patient, that is predominantly ventilated patients, you can use the critical care pain observation tool, that is CPOT, or behavioral pain scale. So next, once you have assessed that how much pain my patient is in, we need to give some treatment. So the most common treatment that we give is the pharmacological management. So we start with opioids. This is the mainstay for ICU pain management. So why opioid is the mainstay? Because it is effective, it is safe, it is short acting and allows rapid dose adjustments. No clear evidence favors one opioid over the other. So commonly used opioids are fentanyl, fast-acting, short half-life, ramifentanil, which is better sedation control and reduces additional sedative needs. Morphine is a slightly longer acting because of its renal metabolism. Meperidine, which is not recommended due to its neurotoxicity. Codeine is a weak analgesic and rarely used in the ICU. But for ICU, you use the top three, that is fentanyl, ramifentanil, and morphine, based on the availability and your need of for the patient. So since opioid is the most commonly used drug, we need to know the adverse effects. These are respiratory depression, that is can reduce the breathing rate, requires ventilatory support if the dose required is high. Sedation and delirium increases ICU stay and worsens long-term cognitive function. Opioid have the side effect of sedating the patients. So a patient once sedated is more prone to be delirious. So GI tract issues, again a common issue, need to be kept in mind. Nausea, vomiting, ileus. This can happen if you're using very high doses of opioids. Histamine release, more with morphine, can cause hypotension and itching. So now that we have opioids and you have used opioids, there may be a situation where the patient is having some side effects of the opioid, or maybe I don't need the sedation aspect, or the pain is not that severe enough. So maybe I can manage the pain with non-opioid. So in those cases, you go for a multimodal analgesia, combining the different classes to get your best management. The common known opioids are paracetamol, safe, reduces opioid requirement. Use it. NSAIDs, effective, but they do have their side effects which can be exacerbated in ICU patients. So reserved only for very, very complicated cases where you probably cannot give either the acetaminophen or opioids. Gabapentin, this is more for the neuropathic pain, and it can cause some form of sedation as well. Ketamine, again, it is opioid sparing, but it causes delirium hallucination. So useful in low dosage, again, a rescue drug not to be used commonly for pain. Regional techniques are going to be very superior because they will be very, very effective and reducing the opioid requirement. So epidural and peripheral nerve blocks, especially in post-op and trauma cases, can be very vital in taking care of the pain, also eliminating the sedative and side effects associated with the opioids. Non-pharmacological pain is also a critical aspect. This must be kept in mind. Physical and psychological approaches need to be given. Repositioning of the patient takes care of a lot of discomfort, even preventing pressure ulcers. So, if you reposition the patient, the discomfort tends to get reduced. This must be encouraged by the nurses. Optimize the ventilator synchrony. Sleep hygiene is important because it reduces the perception of the pain. If the patient is unable to sleep properly, then it's going to be a problem. Massage, heat therapy, transcutaneous nerve stimulations, these have been used and is to a certain extent are good in reducing the pain. Distraction like music, guided imagery, meditation can help. Family involvement definitely helps because it reduces the anxiety and the stress of the patient. Pain. So to sum it up for the pain aspect, the pain assessment should be done routinely, even in sedated patients. Just because a patient is sedated and on ventilator, I will not assess the pain. That not should be the practice. Opioids are the first line, should be used cautiously because they have side effects and they are habit forming. Multimodal analgesia is the key. Combine opioids with NSAIDs, acetaminophen, and nerve block to eliminate the need for opioids. Non-drug therapy are critical and may help in managing mild forms of pain. And individualized treatment is essential because you need to assess the amount of pain, the severity of the pain, and then probably give the best treatment possible to the patient. Next, we will come to the sedation in the ICU. Why sedation? The primary goal of the sedation is to reduce the anxiety and agitation in a critically ill patient. If I am on ventilator and have a tube in my mouth, I am bound to get anxious. So, to reduce that anxiousness and the anxiety and the fact that I'm unable to speak, all these things will increase my stress. To reduce that aspect, we sedate the patients. It decreases the oxygen consumption by preventing unnecessary movements, helps in mechanical ventilation tolerance by improving the synchrony, facilitates nursing care and invasive procedures. Uh, Before starting sedation, consider non-drug interventions like identify the underlying cause of agitation, why the patient is getting agitated. If it is pain, then first treat the pain because pain is more common than other things. So if the patient is having some form of pain, it is better to treat the pain first before sedating the patient. If the patient is dyspneic, patient is having a sense of dyspnea because of the respiratory issues, then obviously we need to sedate. Or is the patient having some kind of a drug withdrawal? Constipation and urinary retention, if it is there or not. Poor positioning in the bed. If the patient is positioned poorly, obviously the patient will be agitated. Addressing these issues will reduce the need for sedation. So before starting any treatment, check on these things. If the patient is having a urinary retention, obviously the patient is agitated. If the patient hasn't passed stool for 4 5 days, obviously they will be agitated. So take care of the easily treatable things first before starting the patient on any kind of a sedative. Next is how to assess sedation and why to assess sedation. Sedation assessment is critical because it ensures that the patient gets the right amount of sedation, neither too deep nor too light, which is going to be very vital for us because preventing over sedation is important because over sedated patients will stay longer in the ICU and on ventilator. Under sedation will cause an agitation, will cause stress, and will worsen our disease. So, validated sedation scales to be used. The most common one is Richmond Agitation Sedation or the RAS. Scale from +4 to -5, and a target of 0 to -2 is our goal. So, try to keep there. Other sedation scores can also be used. Regarding sedation monitoring, there are some advanced monitors available like EEG based monitors like this and all, but then they are not so required. They may be used in patients who are on neuromuscular blockade and extremely deep sedated, but for all routine patients, this is not a modality that is really recommended. The limitations is that it is expensive. In patients who are elderly, it is less reliable, and motion, which is very common in the ICU, will cause artifacts. So these things must be kept in mind before you are spending money and using this kind of a machine. Pharmacological sedation is the mainstay. So choosing the right drug is important. Goal is important. Adjust the sedation to maintain a RAS of -2 to 0. Consider the pain first approach, as I've already said, because pain is really one of the most common cause of agitation. So most of the times controlling the pain is enough. So many of the times you will see the patients are just on opioids like fentanyls without any need for sedatives. So using this approach results in fewer side effects, lowers the cost, and gets a faster recovery. So these are the drugs that are available. The benzodiazepine is the most common drug used for sedation, but it has a side effect that it is will cause delirium. But then this is the drug of choice when you're starting in the beginning. If the patient is deeply dyspneic, requiring higher multiple organ failures, then go with benzodiazepines. You can taper it off after 24 48 hours once the patient starts to improve. But when you know there is a long term need for sedation, starting on benzodiazepines is very important. Propofol is when you want the patients to start get out of the sedation. It's on the later stage because it's short acting. Once I've seen the improvement, I will start using propofol. Similar with dexmedetomidine when I want a lighter sedation. Ketamine is to be used as a uh, adjunct when I have some issues in using the other drugs. But the benefits of having a sedation protocol in the ICU is important because it results in less sedation, which results in faster recovery. Lower rates of delirium, muscle weakness, and infection improve patient comfort and reduce long term complications. Lowers the overall ICU cost because we are using less drugs. And always assess pain and agitation after starting and sedation. Light sedation is better than deep sedation. It improves survival. Daily sedation interruption is critical. Goal-directed sedation reduces ICU complications. These two things must be kept in mind. Analgesic sedation, that is pain first approach, reduces the need for sedatives and also the side effect of the various drugs. Used a structured sedation protocol for better patient outcomes. So, what are the guidelines and the best practice for ICU sedation? Uh, the guidelines say to use a validated pain scale, to use a validated sedation scale, target light sedation -2 to 0, avoid benzodiazepines, screen for delirium using validated tools, prioritize analgesia, perform daily sedation break, that is spontaneous awakening, and also breathing trials. So these are known to everyone. This has been there for the last 10 years. But this is not something which is really implemented in most of the ICUs. So what are the barriers that we are facing in implementing this? So why aren't these guidelines being followed? Because there is a lack of awareness among the ICU team. Because probably the doctors are knowing the thing, but the nurses aren't aware as of now about these things. So we need more education among the people who are actually at the bedside taking care of the patient, that is the nurses. Fear of patient agitation and self-harm is important because once you put the patient on ventilator, most of the time you're thinking let the patient be lying flat without moving any hands and limbs, so that probably they will harm themselves. So that is one of the factor which prevents them from stopping the sedation. Many of the times, because the workload is so high, again constantly keeping sedation score and all becomes a little tedious for the staff, so they prefer giving high sedation and to reduce their workload, that is checking on the sedation daily. Variance in drug availability and cost across the region means that there is no uniformity among the various ICUs about what drug is used, how what dose is used. So inconsistent adherence to protocol is there because though it is known, various aspects are eliminated in various ICUs. So what are the solutions? Education is the most important. Teaching ICU teams about the modern sedation strategy is critical. Structured sedation protocols are important because they give a guideline for daily sedation assessment. Multidisciplinary approach, that is nurses, doctors, the physiotherapist, the respiratory therapist, all must work as a team to improve the adherence. Now, implementation strategy for pain and sedation in the ICU. Ongoing training is important rather than one-time sessions. So, ongoing training, it has to be a continuous process. Every weekly, monthly, there must be classes on this. Regular education improves nursing performance and documentation. Team monitoring and feedback is important to improve the pain and sedation assessment. Communication is essential. ICU networks improve adherence to sedation and ICU management guidelines. EMRs help document pain and sedation assessment. Balanced nurse to patient ratio ensures better patient care and adherence to the protocol. Challenges in the night time is important because sedation may be unnecessarily deepened by night staff because the staff tend to be fewer at the night, and self-extubation risk is high during this time, and because proper management and monitoring is lacking. Solution is having an in-house provider at night which looks after these aspects, that is probably having a shift in charge who is just looking at these aspects is going to improve your patient safety. The ICU bundles for pain and sedation management. Again, we go back to the bundle. I'm repeating it again so that it is easy to remember. A. Assess, prevent, manage pain. B. Both spontaneous awakening trials, spontaneous breathing trials should be given. C. Choose appropriate sedation, avoid deep sedation. D. Delirium. Its prevention, monitoring, and management. E. Early mobilization and physical therapy. F. Family engagement and communication will improve recovery. So why are these bundles important at all? They're important because better than using individual components of this, because if you're using all of this, there is a chance that you will get something out of it. Using any one, two, or combination of this will result in some defect. It reduces mechanical ventilation duration, ICU stay and mortality, improves nursing satisfaction and ICU care quality. We must have a humanistic approach to pain and sedation. This is critical because it prioritizes patient's comfort and dignity, and keeping the patient alert and engaged improves the psychological well-being of the patient. Family involvement helps in recovery. Non-pharmacological pain and anxiety management is important. Music therapy, massages, distraction techniques must be used to reduce sedation. ICU diaries can help the post-traumatic stress disorder in ICU survivors. So the take-home message is ICU sedation should be protocol-driven. Target a light sedation, RAS -2 to 0. Benzodiazepine should be avoided due to high delirium risk. Daily wake up and breathing trials shorten ICU stay and ventilation time. But that doesn't mean that you don't use benzodiazepines. Benzodiazepines should be used in the initial stages. Once you are seen that the multi-organ failure is improving, stop your benzodiazepines and start on some short-acting agents like propofol or dexmedetomidine. Benzodiazepine should be avoided, should not be a reason to keep the patient agitated. This is no excuse to keep a patient agitated. Many of the time people get confused. They think that benzodiazepine should be avoided, means it should be never used in the ICU and the patient should be kept awake. No, that's not going to work. If the patient is having dyspnea, patient is having severe pain, or patient is having the need for sedation or organ support, then they need that sedation. They need to be kept sedated. Do not keep them agitated. Multimodal pain management is important. New sedation techniques like volatile anesthesia, virtual reality show promise for future. The humanistic approach, that is, think about the patient first, prioritize the comfort, mobility, family engagement, which will help in long-term recovery. So if we think about the patient's comfort, that is going to answer a lot of questions. When the patient is very sick, keep them comfortable with good deep sedation, that is -2 around. Once the patient is out of the organ failure, try to keep the patient more awake around 0. So -2 to 0, it's a range. Try to keep -2 in the initial stages. Try to keep it 0 in the later stages. Thank you for your patience.